All right, so increased ICP. So the symptoms of increased ICP. You imagine if you have increased intracranial pressure, you're going to get a headache because it's increased pressure in your head. So that makes sense why I would have increased intracranial pressure. Hold on, something's thinking. There we go. All right, so yeah, increased ICP, you get a headache, right? Usually the first symptom of increasing pressure is going to be ALOC. So they get altered, they get drowsy, lethargic, stoop risk to the comatose state, and of course that's signs of herniation, right? So as you have increased ICP, that's going to start causing, increased ICP elevation. It's going to start leading to brain hypoperfusion because, as we mentioned with like the brain death studies, you're literally are going to swell shut the blood supply to the brain. So then you get less oxygen, right? Less oxygen means you can't keep stuff out of the neurons anymore, and you get more cerebral edema, right? And that's a whole downward spiral that keeps going and going and going until ICP unfortunately leads to herniation, right? And of course, it can herniate downward through that tentorium. If it's coming from the top, if it's just generalized cerebral edema, it's going to herniate, downward. The best, only space it can go is down, right? That's the only hole outside of the skull, right? So it's going to go downward and start compressing the brainstem structures, and then we start getting, pupillary changes, and we get other changes down there as well, right? You start compressing the vessels down there. You start getting maybe hemiplegia. You start getting compression of the pons. You get compression of the pons. What happens? You get respiratory rate changes, right? So your respiratory rate goes down or abnormal, right? So you get Cushing's or Biot's or agonal, right? Respirations or cerebral hyperventilation syndrome. You get all kinds of weird respiratory patterns, right? And as you start compressing the medulla, what happens? Yeah, you lose the SNS activity, right? That's where the SNS originates. So you lose that SNS activity, so you get a low heart rate, right? So with parasympathetic is left to do its thing. A vagus nerve is still able to function just a little bit, right? But the vagus nerve comes off, that's number 10, right? It's still coming off down here, right? There's number 10 right there. You got 11 and you got 12. And then of course 3 was already compromised with the pupillary changes up top. But you got low heart rate, you got abnormal respirations, the SNS failed, right? Or it's failing. You're getting you get this vasodilatory problem happening, and your body's going to respond, and it's going to try to vasoconstrict, right? ADH can try to get released, RAS system is going to try to fire off, and you get some hypertension. So these 3 things together are what? Cushing's tryout or reflex, right? That happens with increasing ICP. That's late signs. These are late signs of herniation. But at the same time, we want to try to catch it before then, right? If you have a neuro patient who is getting bradycardic and hypertensive and abnormal respirations, that's probably a sign of increasing ICP. But before all that happens, you'll start getting what's called intractable vomiting. And what's intractable mean again? Doesn't go away with treatment, right? So I gave every nausea medication. I gave them 2, 3 nausea medications. They're still vomiting. That's a really big red flag, especially if you have a neuro patient, right? Otherwise, unless your patient has like pyloric stenosis, it's not a very common thing to have intractable vomiting as an adult, okay? And ovoid pupils, papilledema, that's, if you have your ophthalmoscope around, you can pop that out and look at the pupils. But it's really difficult to look at on a good day to see if you have that, but that is a sign. And as we mentioned, Cushing's triad is a late sign of increasing ICP. As you start compressing all those structures, you're going to start compressing the hypothalamus, and then you can have SI or DI. It just depends on how it's feeling, right? If you're compressing it, it starts getting stressed out. The hypothalamus is going to start releasing what it can release, which is ADH. It's going to start releasing it to an inappropriate amount, right? So it's called a syndrome of inappropriate ADH release, right? SIADH. Or if you compress the hypothalamus completely, then you're not going to have any hypothalamic ADH release, and you have diabetes insipidus, right? So which one has more P? Insipidus does, right? Diabetes insipidus. All right, so these are all the signs of increasing ICP, and as we see that as the map starts going down, our CPP goes down. What's CPP? Cerebral perfusion pressure, right? So what's the formula for that? It's the MAP minus the ICP, right? What's going in versus what's coming out, right? So you have ICP coming out right here, this increase in intracranial pressure, and you have to deliver a certain MAP, right? And that difference is our cerebral perfusion pressure. So as the CPP goes down, your body's going to try to vasodilate, try to get as much blood supply as it can to the brain, but eventually and hopefully maybe increase the cerebral blood volume. But if you increase the cerebral blood volume, now you're going to increase your ICP more, and that's going to decrease your CPP. So it's a whole downward cycle. We're trying to fix things, but ultimately you're going to start getting edema. You're going to start getting problems with drainage of CSF, right? Because you're going to be having a rapid rise in your ICP. All right, why does your ICP go up? Yeah, edema can go up. You have an expanding mass. You have a tumor. You have a blood increase, right? Sometimes they put blood increase under just your blood volume, but under sheer blood volume because I have a bleed of some sort, but I have this expanding mass that's going to start shifting my brain, and that's going to decrease the outflow of CSF, right? All the CSF that's produced in the brain here it leaves, right? You produce about 500 mLs per day, and that has to then get, it's nice. It washes away all the waste products, delivers nutrients, and but then it has to leave, and it leaves through the venous system at the top of the brain, right? Those things can get clogged with blood, or the downstream, it can be backed up, right? What can be backed up? The jugular veins, right, can be backed up, or the thoracic pressures can be high, or the abdominal pressures can be high, and all that will translate and decrease CSF outflow. And then if that increases ICP, then that can cause edema, and that can cause brain shift. So just right there, we have problems, right? But if we just end up having decreased perfusion overall, decreased cerebral perfusion pressure, that can lead to hypoxia and lead to cellular damage, and that leads to edema. And now we're back to square one again, right? And then just what other things can happen? Decreased MAP just of itself, right? So that can lead to decreased cerebral perfusion pressures. That's why we want to have a little higher MAP target sometimes in our patients that are super sick and neuro patients. And then talk about the blood volume. Yes, you could have an expanding bleed, intraventricular hemorrhage or intraparenchymal hemorrhage, a hematoma of some sort, but also just straight up vasodilation. Hypoxia causes vasodilation, right? So that could cause vasodilation, and that can increase cerebral blood volume, which hopefully will try to fix the problem just a little bit, but that will also increase ICP, unfortunately, right? And as we know, high CO2 and low pH will also vasodilate and put more blood into an enclosed box and increase the ICP even more, right? And as we mentioned, the CVP, right? So our central venous pressure, if that's high in capacity, that's not going to allow CSF outflow, right? So we want to make sure that the CVP is not too high. Are we going to measure it? No, but we just got to think about what would raise CVP, right? Especially the jugular cerebral venous pressure. So the jugular pressure should be as low as possible. So that means we keep the head in what position? Straight or midline, and you also keep the head of the bed where? Yeah, you keep the head of bed elevated, right? 30 degrees is good. That way it's going to improve jugular venous drainage, right? So we are draining our jugular for all the CSF being produced. We're able to drain it into the thorax, and of course the thorax pressures have to be good. So the patient's coughing every 5 minutes. That's probably need an antitussive, right, to abate some coughing, right? If the ICP is still going up, we have sedatives to give as long as our patient is what? Intubated on a little big box over here, right? And we got a vent of some sort. That's okay. We can then now we can start sedating them to lower the ICP. Does that lower the jugular venous drainage? No, but we can get the adequate positioned. We can improve the thorax pressures, and of course, it's catch-22 because the vent puts positive pressure on the chest, right? But sometimes we have to because the herniation might be happening, and we are compressing like the medullary structures, and they aren't breathing good, right? They're developing Cushing's triad and such. Okay, so the CSF has to then go downward, and of course, abdominal pressure is going to be a part of the problem too. So we don't want them to get constipated. We want to make sure they don't have ascites maybe. So we want to make sure we are improving venous return. Okay, and of course we have other maneuvers we can do with the ventilator to kind of fix the CO2 problem, right? We can fix the edema problem with other methods, right? There's some things we can do to fix edema, right? We can pull fluid off the brain. So we're getting into the start of the treatments that we can do for someone who has elevated ICP. It's really thinking. Okay. All right. So the treatment for ICP. Okay. So This sometimes represented as a stepwise therapy, by different steps you can do. There's early interventions you could do and late interventions you could do. I think it's coming up on the next slide or so. But these are kind of breaking it down to how we've been breaking it down. The volume of blood. So what can we do to fix blood volume, right? What can we do to fix brain volume? Okay. So what can we do to fix, to give this a good restart at the break, and we're still going on. All right, we can fix the brain volume there. Now I can't write on my page. Yeah. All right, back in business. Got pen now. I can draw. All right, so yeah, volume of blood. That's our different things we can do to fix this. We have the volume of brain, things we can fix to fix the cerebral edema, and then of course CSF, and that's coming up as well. How to pull off CSF. We talked about getting good venous outflow just right now, right? We can improve venous outflow, decrease intrathoracic pressures, abdominal pressures, right? PEEP is one of those things. High pressures on the ventilator. Trach ties and trach collars, those can compress the jugular vein. The jugular vein is only like less than a centimeter, not even a centimeter. It's like 0.4 centimeters underneath the skin surface. It's very, very close to the surface. You ever watch someone put in a jugular vein central line? It's right there on the surface. You press the ultrasound probe too hard, it goes away, right? So it's very, very easy to compress the jugulars. Preventing Valsalva, as we mentioned, we want to make sure we're avoiding coughing, and of course, if they have a lot of constipation, a lot of straining, we can help that out with enemas and such, and bowel regimens. But suction very, very frequently. Sometimes it's catch-22. If we don't suction, they get pneumonia. But we got to be, we have to be within reason. If we have an ICP monitor, we can see if the ICP going up with suction. We can then, back off if we need to. Right? Hip flexion, that's just straight up, it's going to increase abdominal pressure, right? Abdominal distension, just same with the bowel regimen or ascites, right? And neck flexion, right? Keeping the head midline, head of bed 30 degrees and such, right? And of course, we'll get to the EVD coming up. That's one of our other options, just to pull off the volume of CSF, right? Because as we mentioned, these three things, these are only things that are inside the skull at any one time. So if we want to, reduce someone's intracranial pressure, we got to reduce one of these three things, right? So obviously treat the underlying problem. So if they have a bleed, fix the bleed, right? If it's due to anticoagulant use, they're taking their rivaroxaban, and you got to reverse that. And how do you reverse rivaroxaban? You have a $10,000 option. You have a $48,000 option. The $48,000 option is Andexanet, right? And then the $10,000 option is PCC, or prothrombin complex concentrate, right? That's usually the go-to agent if anybody has any kind of anticoagulant use, right? So even with like warfarin, you say, oh, get vitamin K. Vitamin K is going to work tomorrow, right? Vitamin K takes a long time to work. So give FFP, it's going to work in 4 hours. You give PCC, it's going to fix the problem immediately if there's a bleed, for instance, right? So any other treatment strategy, right? All the things we're doing right here to change blood volume, brain volume, CSF volume are all band-aids on a sinking ship, right? So we need to be able to fix the underlying problem. That's our goal, right? If they have a mass, fix the mass. If they have a bleed, fix the bleed. If they have hypoxic ischemic encephalopathy, well, that's kind of you're kind of in a rock and a hard place. We're just going to monitor it, and we're going to make sure we don't have any kind of exacerbation of blood, brain, or CSF, right? So what kind of some things we can do, right? Decrease the blood volume, as we mentioned. So we're going to vasoconstrict pretty much, right? How do you vasoconstrict? You make sure the CO2 doesn't get too high, because when CO2 gets high, you vasodilate. And again, one of our strategies, we can do hypocapnia, 30 to 35, but when we start getting less than 28, we can actually cause a vasoconstriction to the point where there's no flow at all, right? And again, there's like a one-trick pony or a three-trick pony, because your brain's going to get used to it if you keep someone's CO2 in the high 20s, right? So it's only something you can use to maybe use 2 or 3 times, and then it will, after that, it wears away and your body will get used to it. As we mentioned, keep everything normal in the brain. So normal oxygenation, right? So that's SpO2 of what? About 92, 94%. And again, 50 is a little bit low of a target. Probably want at least 70 probably for that guy. All right, and MAP greater than 60, right? Even then, we can even do MAP greater than 75 for cushion, right? So 75 because what's going on? We got a CPP to worry about, right? We have MAP minus ICP is the actual delivered perfusion to the brain, the cerebral perfusion pressure. All right, avoid hypoxic events, so avoiding low PO2s, right? If we can avoid it. Sometimes if they had like a drowning episode, right, and they have hypoxic ischemic encephalopathy, drowning itself can cause a ARDS picture. I have ARDS with increase in ICP, and that's a problem, right? Decreasing O2 demand. So not only just decreasing the improving the oxygen delivered to the brain. You want to, when oxygen that does get delivered, you want to make sure it's not like, say, oh yes, there it is, and it just sucks it all up, and now the rest of the brain doesn't have the oxygen it needs, right? So that's called the cerebral metabolic rate of oxygen consumption, right? So we want to reduce the amount of oxygen that's being utilized at any one time. A quick one we would know about is normothermia, right? Avoiding fevers, avoiding shivering. That's going to increase the metabolic rate of the brain. So yes, you're maintaining SATs 92-94%, but the curve is shifted to the right, right? And when we look at our O2 hemoglobin association curve, and you're going to be using a lot more oxygen, and it's going to cause a lot more demand, and therefore you can have cerebral edema to the tissue that does not get the oxygen it needs, right? So maintaining normothermia, even sometimes permissive hypothermia. We used to overshoot that all the way down to like 92 degrees, and we don't do that anymore. All right, maintain euglycemia, because as we know that the brain needs oxygen and needs sugar. And we want to make sure that it's not using too much sugar, then that, again, starves the rest of the brain, right? So make sure we avoid hypoglycemia and hyperglycemia events. And as we mentioned, sedation itself can just reduce the curve of oxygen consumption altogether. Propofol can do this, and if really that's not working, we can again pull the big guns and use neuromuscular blockade agents, and we use barbiturates to just shut off the brain to reduce its metabolic rate down to zero. But with the barbiturates, the neuromuscular blockade will reduce it significantly, but not to zero. And then brain volume. So how do we get rid of brain volume? Do we just do a little, frontal lobectomy, right? So I think you don't need you don't need your childhood memories, right? So the options are not to take out brain tissue, but to reduce the brain tissue's size overall, right? So we're not taking away muscle fibers or brain fibers. We're just reducing their size, like what's their swollenness, right? You're taking away their swelling. So we're fixing cerebral edema in some fashion. Okay, we can do diuretic therapy, get rid of extra fluid that might be floating around. Steroids can happen, especially with vasogenic edema, if it's a tumor of some sort, if it's like an infectious process. All right, that's something we could be doing to reduce the amount of fluid that's crossing the blood-brain barrier into the brain itself, right? And then we have hypertonic saline, right? And that's better than mannitol. So, but both those things can take the fluid that is in the brain and pull it back into the vascular space. And hopefully they can pee, because otherwise it's going to go right back into the brain, right? So that's our options to get rid of extra fluid that's swollen around the brain tissue. And a sodium ballpark about 140. That's going to keep your serum osmo in check. And we can check serum osmos to make sure they're good, so that if they're getting too low, we can add something hypertonic to the mix to make sure that the extra fluid that's in the periphery does not, or the vasculature, doesn't make its way into the brain. Okay, what else? So we got volume of brain, volume of blood, and then we got the volume of the CSF that we can fix next, right? So we have different tiers. We can have tier 1, tier 2, tier 3. And of course, tier 3, we can just straight up do a craniectomy. We can take out a piece of the cranium to allow the brain to expand. And of course, that's a very, very last-ditch effort. But we have all these other things we can do in the meantime to fix the volume of blood, the volume of CSF, or the volume of brain. Okay, so osmotherapy. So what's osmotherapy fixing? It's fixing brain volume, right? So it's pulling, so you got your bloodstream right here. So you imagine little salines in here, little mannitols in here, right? Whatever you want to think about, right? Or your sodium of 140 approximately. All that's going to be pulling water from the periphery here, or into the edema, the cerebral edema. It's going to pull it into the blood, right? That's the goal behind this hypertonic, or this osmotherapy, hyperosmolar therapy. We're pulling fluid from the brain tissue into the vascular space, and then of course it then gets deposited, and hopefully we can pee it out, right? So we're increasing the osmolarity or osmolality or we're increasing the concentration of the vascular space, right? Fluid will shift, and that will hopefully decrease our ICP, right? Decrease our intracranial pressure. But just like, hyperventilating someone, your brain catches on. So, right, this is only something you can use like 3 times, 4 times, 5 times maybe, and your brain's gonna catch on. Like, I see what you're doing there. I'm gonna make my own little osmoles, right? My own little osmoles, which are gonna hold on to water, right? So that that's my fluid. So it's gonna make these osmoles hand out over time, usually within 24 hours. So it's we gotta use other strategies if we used all of our X's or all of our strikeouts with osmotherapy. Okay, so what else can we do? So yes, it's going to increase free water in the serum that we need to get rid of, right? So that's why we need to be able to diurese it out. And of course, someone's renal or CHF, it can cause fluid overload, and that can put more stress in the cardiac system. And then you have a heart that fails and decreased MAP. So you can see how this is a downward spiral, or it can increase CVP. If you increase CVP, then we can't, the CVP is right over here, right? CVP, so I make that more visible, right? You got increase in CVP. The venous system is supposed to be draining into the vasculature, right? But if the CVP is going up because I'm a super volume overload, now that's what did you fix in the end, right? So other things it can do, like I mentioned, is increasing our CVP. It's going to increase cerebral blood flow. It will help a little bit, right? As long as we decrease the edema, then we can improve blood flow through the brain. Okay, so we're adding in the interstitial spaces, all this edema that's in there is going to be sucked out into the vasculature, and hopefully your kidneys will then go ahead and pee it out, right? So we have 2 options. We got hypertonic saline and we have mannitol, and the better one is hypertonic saline, right? By a margin. There's a lot of differences between the two, between mannitol and hypertonic saline. Mannitol is really, really strong. It does its thing, but it's going to pull a lot of fluid. So it's going to be, a lot of really taxing to someone that has has CHF, has a problem with volume. Okay, and they did studies and it has worse neurological outcomes. So it's like, well, why don't we just use hypertonic saline instead, right? It can be nephrotoxic as it accumulates in the kidneys. It pulls way too much fluid in the kidneys, destroys concentration gradients, and causes the kidneys to kind of shut down. So that's why it's not great. And then it crosses the blood-brain barrier. It's like, well, that's just what the brain's going to do anyways, right? So that's not great to improve someone's cerebral edema. So the better option is hypertonic saline. And again, it's just hypertonic. It's going to be very, very concentrated saline in there, right? And that's going to be pulling all the fluid from the brain into the vasculature and hopefully reducing cerebral edema, right? And it's best given as a bolus because why? Your brain will make idiogenic osmoles, right? Or not idiotic because they actually do their job. They actually are going to hold on to water inside the brain tissue. So we have to use this as a bolus. Just like a surprise, like, hey, look over there, boom, right? You get a little IV push of hypertonic saline. So that's the best way to deliver hypertonic saline. You often see it as a infusion from the pharmacy, and that's not the recommended way. The recommended way is to give it as a bolus, right? So 3% saline is, it's as a little drip, and of course it's stocked from pharmacy because you don't want someone just grabbing 3% when they meant to grab normal saline. That's a big uh-oh. So it is delivered from pharmacy, and then pharmacy might not be there. They might not answer the phone. They're answering another stat call. So you need to have hypertonic saline. Your patient's crashing in front of you. This is one of your last-ditch efforts to lower their ICP. So what do? You can just grab 2 ounces of bicarb. All right, just hit with a 1-2 punch with bicarb pushes. All right, so 2 ounces of bicarb is equivalent to about 6% of saline, a normal saline, right? And that's 2-3%, right? So that's a quick way to grab the crash cart. Someone's crashing with a high ICP. ICP get in the 20s. They're really looking really bad. They're not breathing well. All right, the respiration is getting really weird, and you're about to intubate them. It's like, well, let's when you intubate them, I know that's gonna put pressure in the chest as well. So can we give 2 ounces of bicarb, right? Because sodium bicarb is made of sodium bicarb, right? It's sodium and a bicarb, 8.4%. If you do all the math, you put them both together, it equivalent to 6% sodium chloride. Okay, so that's a quick way to do it if you have a really if your pharmacy is not right there to manage and bring up your hypertonic saline. And even then, if you brought that up, you have to do about 250-500 mLs bolus. How long does it take you to give a bolus in? If you do it 999, right, it's going to take you at least a half hour, 20 minutes. Does it take you 20 minutes to a half hour to push 2 ounces of bicarb? No, you can just throw that in there real quick, right? And of course, if you do have the fancy 23% saline bolus, right, that's going to require, that's even better, and that's going to be super quick, right? If pharmacy brings that up, then yeah, you can slam that right then and there. Okay, and oftentimes pharmacy might balk at you and they say, I need 3% saline. I go, do you have a central line? So I don't have time to put a central line, but you don't need a central line, right? It's been many studies, a lot of research says you do not need a central line for 3% saline. Greater than 3%, you do, right? As we mentioned before, like in IV titrations, like nobody balks at sodium bicarb or glucose pushes, right? Via a peripheral IV, but they are extremely hypertonic and they are very damaging the vessels. So why aren't we concerned about that? But we are concerned about 3%, right? So yeah, so if you give more than 3%, then yeah, you need a central line. That's fine. Okay, and if you're given a bolus of 2 units of bicarb, yeah, it's nice to put a central line, but if a patient's crashed in front of you, you need to save the brain first, right? What else? We got side effects of hypertonic saline. So it can cause your anion gap to be a little bit screwy because it's adding bicarb or adding chloride, I should say, and it's the bicarb is being pushed in the cells, so your anion gap goes down, and you can develop an acute kidney injury as well with all the sodium chloride. The chloride itself, as we'll find out when we talk about renal, how bad sodium chloride is, and that should be abnormal saline, not normal saline. And it causes a lot of damage to the kidneys. So it can, if you give him the hypertonic version, of course, that can cause damage to kidneys as well. Okay, and it can cause hypernatremia. So you don't want to get greater than 155. Really, you want to target like 140, 143. If they're super sick, you might be a little higher, but really you don't need to go higher than that, right? We want to keep the osmolarity around what? What's a normal serum osmolarity? Normal serum osmolarity is about 280, 300, right? So 300 is perfect, right? If you take a sodium like 140, right, as normal, times 2, that's already 280. You're already perfect, right? And because you have other things that add to your osmolarity as well. BUN adds to it and glucose adds to it, at least a couple points, right? BUN divided by 2.8. So my BUN is 28. I got a, what do I have? So that adds how many points? 20 divided by 2.8. 10, right? So it adds 10 points, right? So that's already 2.8 times 10, and with the decimal over, that's 28, right? Oh, so then that's going to be that's 10 points added to 280 already. All right, so yeah, so 140 times 2, right? That's a sodium times 2 is equal to your 280, right? And that contributes to my serum osmo. And then my BUN adds 10 points. If my BUN is 28, so it adds 10 points. If it's 20, 8.5 points, I don't know, right? And then, so that's 290. And I got glucose, right? Glucose of 180 divided by 18 is 10 points also. So my glucose is 180, it's normal, or normal-ish in the ICU. That's another 10 points. I'm already at 300, right? So to choose a target of like 150 sodium, that's you're already starting at 300, right? And you're gonna be at 320, and that could cause more problems and delirium down the road as well. Okay, and don't feed your patient alcohol as well. Alcohol is also part of this equation as well, just FYI. When we talk about osmolarity later in renal, E2H is also part of osmolarity. All right, so all these things can, you want to keep your serum osmo about 280 to 300. Usually it's about 300-ish. That's where is a good target. And when you're doing mannitol therapy, you're checking serum osm. Whereas when we're doing 3% therapy, we're checking sodiums, right? Checking sodium levels because we have it right there, right? Why can't we just use sodiums for the other one? You could, but the mannitol is an unmeasured osmol, so it's better to measure your actual serum osmolarity. And we'll talk about that more. We talk about renal and unmeasured osmols and osmolar gaps and such. Okay, so you don't want your sodium to rise too quickly. It's okay in the first like 12 hours or so to raise by like a quick 4 points or so, but definitely over 24 hours, you don't want to get a dramatic rise in your sodium. That can cause more problems than good. Okay, and anything else, if it's not given by bolus, you will develop tolerance. So that's why we give boluses of 3%, right? So tolerance can develop, especially with mannitol, and of course, tolerance can develop with hypertonic saline as well, right? So these are the things that we can do to reduce what in the brain? The intracranial pressure, because we're reducing cerebral edema. We're pulling fluid off the brain.
How often should they be getting labs?
So labs are about Q4 hours for osmotherapy, right? Q4 to 6 hours. So with sodiums, Q4 to 6, or with mannitol, Q4 to 6 as well. But again,
ICP or just osmotherapy?
When they're on the actual therapy, for osmotherapy, you're going to do it every 4 to 6 hours. Okay. All right. So ICP reduction. So another just a stepwise thing I was talking about, right? We can do osmotherapy. So where's my osmotherapy at? Hypothermia, induced hypocapnia, hyperosmolar therapy. That's where we just came from, right? So that's a pretty advanced maneuver to help reduce someone's ICP, right? So sedation stuff we can do. CSF drainage we'll talk about coming up on the next slides, where we do an EVD to pull off the actual CSF volume, right? But hypocapnia is a quick strategy we can do. And again, these are just like, 3 times, maybe 5 times with osmotherapy. Maybe get away with 8 times, but really your body's going to adapt to it, right? So on the right-hand side here are your side effects. Your side effects are on the right here and right here. We got side effects from these therapies that can develop, right? We can do nurse interventions, of course. We just reposition them, make sure they're comfortable, make sure we're draining, make sure the jugular venous pressure is not too high. The CVP is on the lower side, so we've got good thoracic pressures, good abdominal pressures, and everything is draining properly. So positioning can help. Make sure we're not doing too much suctioning. We are not going to cluster care. We're going to separate out the care so that we're not increasing the ICP dramatically for like 20 minutes, like bed bath, suction, right? Bam, wound care, right? So it's all, you're just going to try to spread it out as much as possible, okay? And you got to recognize that the patient is deteriorating by doing neuro checks Q1 hour. We're assessing for Cushing's triad. We're assessing for cranial nerve dysfunction, right? Assess for pupillary changes and such. And of course, we have pharmacological therapy we can look at as well. We got propofol to reduce ICP, and it's preferred because once you take it off, it's gone in 10 minutes, right? So we can adequately get a good neuro exam afterwards. And then we got neuromuscular blockade. So we have this will shut down the oxygen demand because we oftentimes require more sedation to begin with. But this is they found it's better to actually give PRNs than giving like a continuous infusion of the neuromuscular blockade. Usually at the first sign of increased ICP, you'll get some pushes, and if it's still sustained, then yes, we'll switch over to a paralytic infusion. And then barbiturates. This is where you are going to pump all the brakes, and we're going to shut off the brain, right, for 4 days at least. And that's going to last, and it's going to work. It's going to definitely reduce their ICP. Okay, we talked about osmotherapy just now, right? And of course, we're going to talk about CSF drainage coming up. And one of the other options all the way up at the top here is a decompressive craniectomy. And of course, that's a not worst case scenario, but I guess it is. It's a last ditch effort that you would do to alleviate someone's ICP. Is just take off the lid and hopefully it expands, right? And it does expand, unfortunately, and sometimes that can be detrimental just as it was intended to have risk-versus benefits. Maybe it was going to help allow some of the pressure to expand, but sometimes they have such a big mass or big bleed that it's going to then cause a transcalvarial herniation, right? So these are options we could do, and again, these are all problems that can be addressed. And who needs to be involved with this process is, your neurologist, but usually your neurosurgeon needs to be involved as well, right? Because your neurosurgeon can place your EVD, and they know this patient's on the radar. They the patient's not doing good. I might have to do a decompressive craniectomy, right? So any kind of neuro patient, you probably want to have both on the case, just as a safeguard. You have neuro and neurosurgery, right? Neuro deals with all the, they do, definitely outpatient situations. Yes, your neurosurgeons deal with outpatient stuff too, but your neurologist deals with multiple sclerosis and all kinds of other neurological diseases, right? Fibromyalgia and such. But they are going to also be managing strokes. They're experts on strokes, for instance. They're experts on ICP management. Can they do an EVD? No, a neurologist can't do that. Can they do decompressive craniectomy? No, but they really know how to make it work, that it knows that it may work. Okay, so you want to involve neurosurgery. You want to make sure they are involved, right? So we can get them their input if there's something else we need to do that we're not thinking about, right? Is there some bleed that's happening, right? So the neurologist can say, hey, I found out they're on warfare in their home, or I found out that they were on a dabigatran, an old style direct oral anticoagulant. So we'll go ahead and reverse that, right? Let's give a reversal agent. Okay, Octaplex is the same thing as PCC. Okay, so we have other things we can do to fix the increased, the intracranial hemorrhage, and of course we might have to drain it. We have to figure out what else is caused. This could be an aneurysm, right? So the neurosurgeon has to be involved to fix an aneurysm, for instance. Okay, and as we mentioned, all the stuff needs to be normal, or EU, right? You have to have normal capnia, you have to have a normal oxia, you're not hyper or hypo. You have a normal tension, you might be a little bit more on the hypertensive side to get a better map, so we get better cerebral perfusion pressure. And of course, we want to make sure that we have a good temp, because if the temp goes up, what happens? Increased metabolic rate, increased O2 consumption. So we got to make sure that is on the lower side as well. Okay, and of course acidosis, all other things need to be normal. Okay, so these are a stepwise thing that we can then, we're going to be looking at our options, and of course calling to say, hey, the ICP is still elevated. What else can we do?